Okay, so the next section is actually Christof again. So can you pull up the slides, Mary? The next one, please. So Christof's going to start us off with a short intro, about 10 minutes or so, on malunions, and then we'll again do this rapid fire case discussions. We already introduced Christof, and go ahead, Christof.
Thank you very much. Next, please. So I just want to give you a short introduction. Malunion means the fracture is healed, but with a malalignment or functional limitation. This can be due to no fixation, like an insufficient non-operative treatment or an insufficient surgical treatment. As we've heard, most of us think it's from insufficient surgical treatment that we see problems of. Next, please. On the femur, it's quite common. It seems to be a little bit related on the technique, but nevertheless, the technique is only as good as you use it. So I would be careful. But in this study, we've seen like it was reported that there are 2% of Malunions in a rigid nail group, 12% in a submuscular plate group, and up to 22% in a flexible nail group. But again, this is very dependent on the experience with the different techniques. Next. In tibia, there is this classic paper that showed that up to 30% of children treated for fractures might end up with some kind of angular deformities. Next. In a more recent meta-analysis, these numbers are lower, and it just shows that we, as a surgeons, do have a good learning curve over time. And Malunion was found in only 8.5% of cases, and the Lengthening discrepancy in 5% of cases. So that's approximately what we are looking at as at the tibia. Next, please. We always think of remodeling, but there are limits. And remodeling is, of course, age dependent. And we do know that in the first 2 years, there is huge remodeling. But especially in the later years, remodeling can be very limited. So also pro and recovadum remodel more than varus, remodel more than valgus. And in fact, torsion is the deformity that remodels least. Next. So this is also why we see a lot of torsional deformities. In a paper of Salem and Kepler, they showed that up to nearly 50% presented with 15 or more torsional malalignment, 15 degrees, following flexible nailing. And another paper stated that there was no significant correction after 1 year. This is maybe not so surprising, but they stated that torsional deformities up to 25 degrees are well tolerated. And I'm not so sure if I fully agree with that. Next. So we do see those problems quite commonly. This is a 13-year-old after a skiing accident that was treated with flexible nails. And he presented 2 years later with this valgus deformity, and especially with a big rotational deformity. On the left side, 20 degrees of femoral antetorsion, and on the right side, 23 degrees of retrotorsion. This led to quite a significant walking problem. Next. You can see in this case, kind of nice solution is to use a nail to correct both rotation and the alignment. And you can do this today with nice nails that are specifically designed for kids. Next. And you can see here, this is the result of the correction with a nice mechanical axis, and the torsion was corrected. Full weight period was about 4 weeks after surgery. Next. Another skiing accident. You may see that if there are fractures around osteo, some are associated with skiing. And again, a flexible nailing that resulted in next procoadum and next, please. Rotation deformities. In this case, we did an MRI to measure the rotation. And again, same solution. Next. With full weight bearing again after 4 weeks, which is a really easy solution for kids. Next. And a good follow-up. We removed the nail after 1 year. Next. We can see the same problems in the tibia, in this case combined with a shortening of 2 centimeters. Then again, we can use a nail, in this case the lengthening nail, to correct the torsional deformity as well as the shortening. Next. And you can see 2 centimeters of lengthening and correction of torsion and a good healing of the lengthening area. Next. Sometimes we have these mixed cases where you can't really find out what was like the result of physeal injury, malunion. So this patient had a supracondylar femoral fracture with some malunion, but also a tibial fracture, and there was some infection. So we don't really know what was the reason for the problem of the growth plate in the proximal tibia. There also was some varus deformity at the distal femur and a massive hyperextension. Next. Which was like really one of the problems for him. And you can see the PPTA was largely increased. Next. In this case, as we discussed before, we need to close down the physes to make sure we don't get a recurrence. We treated the femoral deformity where we saw that the physes was still viable with guided growth, and put on an X-fix. And you can see next, fully corrected the PPTA, so the recovatum, and also the alignment. And you can see on the final X-ray after completion of growth, it lined up nicely. Thanks. Next. Another case I want to show you with another multiplanar Malunion is a case of a 15-year-old that had a plate fixation at the age of 12 and healed in this varus deformity, which was by itself a problem, but another problem was, again, hyperextension at the knee joint. In this case, as the apex of the deformity was very well approachable with an acute correction using a nail, we decided to do that. And next, please. And that's what we did. We planned out the case with an acute correction with a temporary X-fix in both planes, and with a reaming in a way that we correct both deformities. Next, in those cases, you need a lot of blocking screws to make sure that your initial correction stays the way it is during lengthening. If you do a lot of, if you do an acute correction like this, it is absolutely recommendable to perform a percutaneous fasciotomy of at least the anterior compartment, a technique that's very nicely described by the Baltimore group in this book, which is seated here. And next. We got a nice alignment. Full weight bearing was possible after 4 months, and also a good correction of the recovatum, and we were able to remove the nail after 2 years. Next. So in summary, I think, of course, the primary goal is to prevent malunion. We need to be aware of the limits of remodeling. So sometimes you need to be careful that we don't get the hopes out too high. And I think in case it doesn't remodel, we just need to be sure that we have all the different tools to get an optimal correction in the end. Thank you.
Thanks, Christof. That was great start. And we're back on time, actually a minute ahead, which is great. And next, it's my pleasure to introduce Matthew Varghese. Matthew is a dear friend. He's the head of Department of Orthopedics at St. Stephen's Hospital in New Delhi, India. And he's a world expert in polio, clubfoot, road traffic, accident prevention, and many other orthopedic conditions. He's won numerous humanitarian awards, including recently the One International Humanitarian Award. And Matthew's going to talk about deformity correction, keeping it simple. Thanks, Matthew.
Thank you, Sanjeev. Thank you for having me for this session. Can I go to the next? Deformity corrections can be very complex. This 12-year-old boy came to me with a history of crush injury to his leg, treated elsewhere, and had a severe deformity of his foot and leg. Can I have the next slide? That's how he walked. He was advised surgery, including flap correction and extensive surgical intervention. Next slide. That's the view from the side when he's walking. Next. So severely angulated distal tibia, severely angulated fibula. The tibiofibular joint was fused with a very badly
Did we just lose Matthew?
Yes.
Okay. Matthew, your connection got lost. Maybe let's just scroll through the slides while Matthew comes back. So let's go slow. Unless, Matthew, if you turn off your video, maybe it'll work for you better. Can you turn off your video? Okay. Let's see. Is Matthew still there? Okay, we can always, come back, I think. Mary, let's just do that. We'll pause on this one. Just remember where we stopped, and then maybe go to the next one. And I think it's Tim's next. Hi, Tim. So it's a great pleasure to welcome Dr. Timothy Nunn. He's the medical director of Cure Children's Hospital in Ethiopia. And he's again won numerous awards, including the recent African Mission Healthcare Gerson Lashame Prize. And he started the pediatric spine program in Cure Ethiopia. And so Tim is going to talk about a case of intra and extra-articular osteotomy related to a Hoffa fracture. So thanks, Tim.
Hey, thank you. And it's a great opportunity to give this talk. Thank you. I'd like to share a case of a Hoffa fracture malunion in an adolescent from Ethiopia. So the history here is this is a 16-year-old boy, 3 years after a pedestrian bajaj injury. And a bajaj in Ethiopia is the local name for a tuk-tuk. He had increasing lateral knee pain on walking more than 100 yards and progressive valgus knee deformity. He's dropped out of school and couldn't work due to limited walking distance. And he was referred to us by a local NGO organization. Next slide, please. So there's a video on the right. You can see that, clearly he has valgus deformity. On examination, he has 15 degrees of fixed flexion deformity of the knee with a hard block to extension. And it was actually quite painful to attempt full extension of the knee. Next slide, please. So you can see from the radiographs the valgus deformity, and on the lateral here, a suggestion of a Hoffa fracture malunion. Now the lateral distal femoral angle was reduced, and we surmised that was partially due to an intra-articular deformity and partially due to an extra-articular deformity. Next slide, please. I think you can see the intra-articular deformity here, with the deformity preventing full extension, essentially being a block to full extension of this lateral condyle. Next slide, please. And we can see here a 3D reconstruction aiming to show the same with the valgus and the intra-articular deformity. Next slide, please. So I discussed this with a long-term mentor of mine, Dr. James Fernandez, who's a consultant pediatric orthopedic surgeon at Sheffield Children's Hospital. And just want to take a minute to urge all trainees on the webinar here to maintain good professional relationships with your trainers and mentors even after you've finished your training. And this relationship for me has been very key in my development. So the suggestion was to use a hinge fixator with gradual distraction and allow the knee to fully extend. So essentially to disimpact the deformity in the knee joint, and then perform an intra-articular osteotomy to reduce and fix the fragment, and try all the time to keep range of movement. And the second stage was then to address, once the intra-articular anatomy was restored, to address the axis alignment with a supracondylar osteotomy. So here you can see on the left image, there is a fixator has been applied with a hybrid fixator with a medial pin going into the medial distal femoral condyle, and partially, not all the way across, because that would have been blocking our osteotomy. So next slide, please. So after the distraction was achieved and the knee was gaining full extension, we approached the osteotomy site with the distractor in situ in a minimally invasive manner and placed anterior-posterior screws to fix the fragment and one lateral to medial screw. Next slide, please. Here you can see the fluoroscopy and the immediate post-op radiograph, and we encouraged the patient with physiotherapists to keep the knee moving throughout. Next slide, please. And then finally, once that had healed, we went back as planned and did a distal femoral osteotomy to correct the residual valgus deformity. Next slide. And could you please play the video? Thank you. So this lad, this adolescent, was on follow-up, gratifyingly walking very well and fully squatting. And we were pleased to hear about 1 year after surgery that he had returned to school and in fact had a part-time job. And we've been measuring his disability score as per the WHO HUDAS form, and that had improved significantly from 73% to 0. Next slide, please. So the learning points that I took from this case was that, of course, having a good mentor is very important, but reducing after arthrodiastasis can be a very helpful tool. So distraction of the joint enables reduction of the intra-articular deformity. And secondly, maintaining range of motion throughout treatment, I think, was key also to a good outcome. Thank you.
Great. Thanks so much, Tim. That was awesome. We're going to go back to Dr. Iobst, Chris Iobst. And Chris is going to present a case about malunion. Yeah, we'll come to Matthew towards the end of our case discussion, if that's okay with you, Matthew.
That's fine. That's fine.
Yeah.
Sorry, I don't know, for some reason it just went down at that time.
No problem. Yeah, that's great. Okay, Chris, please take it away. Thank you.
Thank you again, everybody. It's a pleasure to be here. So this is a case of malunion after femoral lengthening. Next slide. I'm presenting a case of a 13-year-old female who has underlying diagnosis of congenital femoral deficiency and fibular hemimelia. She had an attempted femoral lengthening with a uniplanar external fixator at another institution that had poor regenerate formation and bent into varus, and they tried to salvage this by plating it in situ. So a teaching point here is just it's a good example of how the muscle forces can deform regenerate bone in the mid to distal femur. If you're doing a lengthening with a uniplanar fixator, consider acutely placing the distal fragment into some valgus initially so that as the varus deforming forces are applied, the fragment actually gets pulled back into neutral and not into a deformed varus position. Next slide. Here's a standing full-length radiograph of this patient, which demonstrates that she has about a 13 centimeter limb length discrepancy in addition to the diaphyseal varus deformity. So looking at this radiograph, perhaps our initial inclination would be to simply straighten out the diaphyseal deformity. Next slide. You can see if we do that, as we've done virtually, we now have a valgus situation with lateral deviation of mechanical axis. So we have to ask ourselves, why is that happening? Next slide. So you can scroll through the next two images on the same slide. So you can see that this kind of uncovers two teaching points. Number one, don't cut corners on your deformity analysis. Go through all the steps religiously to prevent making errors. And by doing so, we uncover the fact that there are two apices in this femur, one varus and one valgus, that effectively cancel each other out to create the neutral overall axis. The second teaching point is that in skeletally immature patients, they will develop compensatory deformities trying to correct their axis. So in the case of the femoral diaphyseal varus, the distal femoral valgus occurred to counteract and correct it. Next slide. So now that we know that we have a multi-apical deformity, we have to decide how to fix it. And it really just depends on your comfort level as a surgeon, but I'm always in favor of intramedullary fixation whenever possible. In this case, with the additional component of limb length discrepancy, it might be tempting to use an internal lengthening nail, but I believe this would put too much stress on the nail. I would rather use a trauma nail to get a united, straighter femur and then come back later and deal with the lengthening in a more optimal setting. Speaking of creating an optimal setting, next slide. I chose the first step actually to remove the hardware as a separate first step. You never know if there'll be broken or stripped screws that may need to be dug out of the bone. And I don't like making reconstructive osteotomies in the setting. Can you show this picture, please? I don't like making an osteotomy in the setting of bone and soft tissue trauma. Next slide. So now you can see our plan was to perform two osteotomies in opposite directions and maintain the alignment with a retrograde femoral nail. Next slide. However, we have not even mentioned the sagittal plane of this patient. As you can see, the bending of the regenerate also created an accentuated apex anterior bow of the femur of about 45 degrees. So the other teaching point is that when lengthening with a uniplanar fixator on the femur, consider putting the distal fragment into some extension acutely to counteract the tendency for it to fall into apex anterior deformity. Next slide. Our next consideration has to be where the apex in the sagittal plane lines up with our coronal plane apices. Luckily, in this case, the space in the center of the plate looks like a reasonable option to correct both deformities simultaneously. I like to do a retrograde nail correction using a rigid reamer. The reamer is helpful because it indicates the level where you need to do the osteotomy. You simply advance the reamer until you hit the cortex, then you make an osteotomy there so you can redirect the reamer up the center of the canal again. Here, the distal osteotomy was performed when the reamer hit the medial cortex of the distal femur. Next slide. We then continue reaming, following the path in both the coronal and sagittal planes with fluoroscopy. When we hit the anterior cortex and the diaphysis, we made our next osteotomy. And this method allows you to perform all your osteotomies percutaneously, which enhances their ability to heal. Next slide. Here you can see the immediate postoperative images demonstrating the correction of both the AP and lateral planes before and after shots. Next slide. A few months later, we've achieved union at both osteotomy sites. We have now created a substantially straighter femur, which will make subsequent lengthenings easier. Next slide. In terms of managing the limb length discrepancy, all of the traditional options still apply. Because of her large discrepancy and relatively short stature, the shoe lift and acute shortening on the other side were not chosen. Therefore, we discuss lengthening options. Again, we try to avoid using external fixators on the femur at all costs, so we chose to move forward with an internal lengthening nail. Next slide. Here are the initial postoperative radiographs after exchanging her trauma nail for an internal lengthening nail. We tried to choose an area in the distal femur to make the osteotomy that was outside of her previous regenerate and above the most recent osteotomy site. Next slide. There's several points that I'd like to go over with you that I think I should bring up regarding this transition from a trauma nail to an internal lengthening nail. Number one, she's had a previous lengthening with an external fixator, so you need to be careful to discuss with the family that there's a slightly increased risk of infection due to the colonization of her previous pin sites from the fixator. Number two, this patient has already had a previous lengthening of the femur, so you need to adjust your latency period and your rate and rhythm accordingly. You also need to be more vigilant of the soft tissues because she's already had a lengthening that stretched the tissues in this congenital setting. Number three, technically, it's not as easy as just pulling the trauma nail out and sliding in a lengthening nail. The nails have different contours, so you'll need to ream the canal to adjust for this difference. And then finally, you will also want your new nail to be longer than the first nail, so the nail covers the proximal interlocking screw sites that can become stress risers if they're left at the end of the new nail. Next slide. So here shows radiographs of her 5 centimeter lengthening with no deformation as it had occurred previously. Next slide. Radiographs again demonstrating consolidation of the regenerate bone and a final comparison of the before and after in the sagittal plane. So my final take-home messages are, do not forget about the sagittal plane in your deformity analysis. Number two, don't cut corners on your deformity analysis. There may be a hidden secondary deformity, especially in skeletally immature patients. Number three, don't get too aggressive with your surgical plan. A heroic attempt to straighten and lengthening everything all at once in this patient may have led to a poor outcome. Separating everything into stages where you have a better chance of success is a better strategy. Number four, know your limits as a surgeon. Don't try to do surgeries that are outside your comfort zone, and don't invent new surgeries. And then finally, understand the limits of your implants. Internal lengthening nails run into problems when you ask them to do too much. Thank you.
That was awesome. Thanks, Chris. Okay, we're going to move some talks around because Dr. Diallo's not here. And we're going to do Dr. Gardner. Dr. Gardner had to step out for a family engagement. So, but he's recorded his talk. So if we could just play that. Rick's got a talk on malunion with fragile bone. So Mary or William, if you can play it. Thank you. And keep the questions coming, guys, on the
Hello, my
Q&A.
name is Rick Gardner. I'm a children's orthopedic surgeon from the Hospital for Sick Children in Toronto. And again, it's a real honor to be with you today. Thank you very much indeed for Sanjeev for the invitation. So this case is from Zimbabwe, from Cure Children's Hospital of Zimbabwe, an 11-year-old male who had sustained an injury 2 years previously following a fall from steps. No other long bone deformity. He was mobilizing with one crutch at a 5 centimeter leg length discrepancy, a marked limp, and pain around the proximal femur. His radiographs were predominantly showing a proximal femoral non-union with severe coxa vara, very osteopenic bone, a gentle femoral bow. And this combined with his physical features suggested osteogenesis imperfecta. And these were a challenge because you've got soft bone, you've got the severe deformity with likely tight abductors and potentially tight psoas. It's difficult to access in many LMICs a cephalomedullary implant which will fit a pediatric patient, and the physes are of course open, and so that also restricts some of our choice of implants as well. And overall, there's a high risk of periprosthetic fracture and metalwork cutout in such situations. So, of course, dealing with cases of osteogenesis imperfecta, combined medical surgical management is key. And considering preoperative bisphosphonates, we often use zoledronic acid. 1 or 2 doses with a surgery stage 3 months later has made a big difference to the quality of bone and the satisfaction of our surgical outcome. The severe deformity, the use of the abductor slide has made a big difference for us. And it's a simple incision over the iliac crest, taking subperiosteal elevation of the abductors after doing your apophyseal split, feathering that cop down to the back of the SI joint, and then through the Smith-Peterson interval, being able to do an over-the-brim psoas recession if that looks like it'd be beneficial, and then do your lateral approach through a separate incision, and it heals very reliably. And of course, at the end, once you've done your correction, that lateral apophysis is dragged down as those abductors tension, and you need to take off the top of the crest, much like you would for a Salter osteotomy, before closing the apophysis and allowing those abductors to be effectively brought down and lengthened. Without the option of a cephalomedullary implant, two-stage surgery can often be useful. A corrective hip osteotomy followed by anterograde rodding, but this can also be done using a retrograde rod with some variant like a fascia duval rod, which can lock into the distal femur without causing any growth issues. In this case, we chose just two-stage surgical option using a locking plate, which is available from many of the Indian manufacturers, which have made a big difference to us. Often you need to, in these severe deformities, do the osteotomy first before you can put your wires in, given the deformity. But he had the abductor slide first, then the lateral approach, subtrochanteric osteotomy, wires in up the neck, 130 implant to get a reliable 130 neck shaft angle. But of course, the configuration of the triangle means you can't slide a rod from the top end. Now, you can do a retrograde rod, like I was saying, with the osteotomies, and then slide the rod up and pass the screws around the plate is another excellent option. But we chose this two-stage in this situation to get the best possible hip correction. And then 6 to 8 weeks later, came back to do the anterograde rodding, which was a simple rush rod with adjustment of the plate, removing the bottom screw of the triangle, and then adjusting one of the front to back screws, then one of the anterior or the posterior screws, to allow passage of the rush rod going down anterograde. In this case, it needed a 2-level osteotomy. And then using the screws to pass around the plate. The bone was so narrow in this stage that was only possible with one of the screws. We used a cerclage wire around the bone. And sometimes the bone is very, very soft in these children. The cerclage wire can cut through. And what works really well is doing an anterior to posterior drill hole just on the medial side of the rod. So you can pass your cerclage wire around medial to the rod through the bone, and then screw it, then tighten it out onto the plate. Gives you a really good bite between rod and plate without fear of that cutting through the medial bone. And that can give you a great hold for these plates. And then, of course, mobilizing the child with future bisphosphonate management. And we found that to be a reliable way of dealing with these severe deformities in soft bone. And gradually that diaphysis will thicken up as the child walks. So thank you very much for your time. Just a really recommendation of a high consideration of combined medical management for the bisphosphonates for these children. An abductor slide can be very helpful, and two-stage surgery can also be very helpful in these severe deformities. Thank you very much for your time.
All right, awesome. That was Rick's talk, and we're just going to move along. Next is my dear friend Scott Nelson. Scott's currently an associate professor at the Department of Orthopedic Surgery in Loma Linda. He spends a good amount of his time down in Haiti in Port-au-Prince, and is the medical director and chief of surgery at the Haiti Adventist Hospital, and has won numerous awards, including the Humanitarian Award from the American Academy of Orthopedic Surgeons. And Scott's going to talk about fixator-assisted nailing with lengthening-over-nail. Thanks, Scott.
Thank you, Sanjeev, for being part of this and for getting us all together this morning. This is a case that I recently did in Morocco, and the patient presented with a limb length discrepancy and a varus deformity from a physeal arrest in the distal femur. There's an attempt to resect the bar and place some cement in there at one time, and also epiphyseal the contralateral to avoid excessive limb length discrepancy. The LDFA on the left side was 112 degrees, and we also have a compensatory deformity that developed in the proximal tibia. Next slide. There was an 8 centimeter limb length discrepancy and a 20-degree knee flexion contracture, which also correlates with this deformity that we see on the sagittal x-ray here of 23 degree less than normal PDFA. Next slide. So there's several options here. We can consider the distal femur correction with intramedullary fixation, plating, or external fixator. And then we need to consider what's necessary to perform the lengthening. This can be either done distally in the femur or proximally. It could be done simultaneous with deformity correction or stage. In this setting, the intramedullary magnetic nail was not an option, and so we were basically faced with doing a lengthening-over-nail versus external fixator only type of nailing, and then also the consideration for the left proximal tibia correction. Next slide. So I chose to do this with a fixator-assisted nailing and simultaneous lengthening-over-nail setup, and this is the start of that, similar to what Chris just presented, lining up our distal reamer with the desired axis of that distal segment and actually just circumventing the bone cement that was placed in there for the physeal bar resection. Next slide. And we also had to take into consideration the sagittal deformity. It's actually quite difficult to correct more than about 10 degrees of sagittal deformity with these fixator-assisted nailings, at least in my hands, but we were able to correct 20 degrees in this case. And once we put that reamer in, we placed 2 pins in the distal segment. I placed one anterior to posterior and one lateral to medial to set up the external fixator, and one in the very proximal part of the femur. Next slide. And this is what it looks like. We use the bend in the retrograde nail posteriorly instead of the normal contour to help correct that 20-degree deformity. Next slide. And then perform distal metaphyseal osteotomy. Usually I do this about 6 centimeters above the notch to allow for 4 centimeters of fixation in the nail with at least 1 centimeter between the osteotomy. And in this case, we had to do quite a bit of correction, even more than 20 degrees, and place the nail as long as possible in the diaphysis to allow for the next step, which I'm going to show you on the next slide, please. Here we chose to do a midshaft osteotomy also because of the large amount of lengthening, 8 centimeters, that was needed. I felt like doing that right at the level of the knee would create a lot of difficulty for physical therapy and maintaining knee range of motion. And also with that big deformity correction that we did there, the reliability of the regenerate was perhaps a little bit less than it would be in some cases. We know that correcting up to 20 degrees can be reliable, but beyond that, it's a little bit questionable. And so next slide, we spanned the distal osteotomy with the external fixator pin clamps for additional fixation there, and then placed the pins proximally outside of the nail to perform lengthening at the end of the operation. You can see the range of motion with full knee extension. Next slide. And take-home messages here are that there was another slide that I added for some follow-up showing good lengthening. The patient actually had a premature consolidation. They had to go back and perform another osteotomy adjacent, but the alignment and length restoration has restored this patient to full function here. And take-home messages are that using fixator-assisted nailing can really facilitate accurate alignment and assessment of deformity correction, because you can fully extend the knee with the fixator on and then place the nail. And already discussed osteotomies of at least 20 degrees correction we know can be combined with lengthening procedures. We published this in the JAOS with Chris Iobst a few years ago using magnetic nail. And physical therapy is easier with the more proximal femoral osteotomies in relation to knee range of motion. We can talk a little bit about joint line obliquity and matching distal femoral proximal tibial angles. My acceptable range is LDFA between about 85 and 95 degrees. And I didn't end up placing a hexapod in the proximal tibia as planned because I had ended up overcorrecting the femur a little bit and the alignment ended up being perfect. But I was planning to correct that proximal tibial deformity, and that's a great way to fine-tune the results of a femoral correction if there's some deformity present in the tibia.
What a great case. Thanks so much, Scott. I'm sorry if there was a slide missing for you at the end.
Oh, no, it's okay. I sent it kind of late to Manny, so I don't know what happened to it, but it's okay.
No worries. We'll catch up in discussion. Okay, let's finish Matthew's talk. So, Bridget, if you can, yeah. So let's start where we stopped. Okay, Matthew, go ahead, please.
Thank you so much, Sid. For some reason, it went off exactly at that time, the connection. The next slide, please. Yep. So what were the findings? Severe valgus at the ankle, badly scarred skin with scars adherent to the underlying bone and the joint. No movement of the ankle, loss of the extensor tendon function, however, did not have a toe drop because all the extensor tendon were tethered to the scar. Next. So that's the X-ray picture, exactly as the clinical picture was, with severe valgus deformity at the ankle. The physis was already fused, ankle joint was fused, the tibiotalar fusion was there, but in a valgus position. Next. Post-traumatic, post-infective ankylosis of the ankle joint with severe valgus of the ankle was the diagnosis. What are the options? Next. Plastic surgery for flap correction, that is what he was advised. First stage, and second stage elision of correction of the deformity with slow deformity correction. I felt this child may have difficulty accepting it. They ran away from the plastic surgeon because they did not want the plastic surgery to cause a flap raised from some other side to come to this side. So they didn't want another scar on another side. So we chose a simpler option. Next. We thought we'll do a fibular osteotomy, supramalleolar V osteotomy, and a simple KY fixation. But the catch was we were not sure whether we'll be able to manage the incision through the scarred skin. So next. Next. Let's put up on the table. So the key to doing these tricky procedures is you have to go straight down to the bone. If you're not planning a flap, you can get away with simple KY fixation or even an external fixator, but do not undermine too much. Just go straight down to the bone, keep just to the bone, and then do your osteotomy. So that's how it was done. Straight down to the bone, no other raising of flaps, just the osteotomy, and correct the osteotomy acutely and do the correction with KY fixation. Next. Incision straight down to bone, no undermining of skin, cross KY fixation, and plaster of Paris cast immobilization. Fortunately in him, the limb length discrepancy was only about 1.5 centimeters. We could manage without any lengthening. And even if there was a shortening, I would have done it as a second stage Elizabeth procedure. Next. That's the X-ray picture. Nicely corrected valgus. Next. After removal of pins, fused ankle, corrected deformity, valgus was not there, straight foot and leg alignment. Next. So possible to correct even severe deformities with very simple techniques using KYs and plasters. Very patient friendly. Thank you.
Thanks, Matthew. I mean, this has just been such a great session because we've seen the entire spectrum, from real fancy lengthening nails to real simple techniques, and everything's effective in the local environment. So beautiful. If our panelists can switch on their videos, and Mary, if you could run the poll question. So, okay, we just have one question just to kind of understand what your challenges are. So, in your opinion, what is the most significant challenge in managing post-traumatic malunions in children? Is it timing? Is it accurate pre-op planning? Is it the actual execution of the osteotomy? Or is it the family expectations and compliance with the patient? I know they're all pertinent, but What's the most challenging of these all? Okay. I guess we can end the, well, it's still going. So, okay, here we go. So, interestingly, about a third of you said timing, and another third said accurate pre-op planning. And then technical execution of the osteotomy was 20%, and family expectations only 13%. So that's interesting. And that's not surprising, right? They're all challenges, but we got to think of all of these things when we're trying to treat a kid with a malunion. So let me just open up a case and then we can go on to discussion. So this is a case I actually saw, well, I've been following for a couple of years, but we just presented it at our local deformity conference too. It's a patient that was seen in our practice, initially not treated by me, but very appropriately treated, I thought. But a 12-year-old male pedestrian had a isolated injury, closed fracture, minimally comminuted midshaft tibia. Okay, I think there's a poll question that goes with that. All right, what would be your preferred treatment method in this 12-year-old? Close reduction and casting, elastic nailing, rigid IM nailing, ORIF with plate fixation, or X-fix? So again, 12-year-old, little bit of open physis, male, and I don't know, I would consider this maybe not the most length stable fracture, but not super unstable with posterior comminution. And again, we're talking in your environment, not what the textbook says, but how would you treat it in your practice? As the first. Okay, so interesting, 40% said elastic nailing, and pretty close, 34% close reduction and casting, 9% IM nailing, and 11% ORIF with plate fixation. So not many rigid IM nailing, and 5% X-fix. So interesting. So elastic nailing and close reduction. So let's go to the next slide. So my partner treated this with close reduction and casting, and they had to wedge the cast a bit to allow for, correction of the varus and recurvatum. And let's go to the next slide. So interestingly, here he is 10 months later, and he has a leg length difference of 2.5 centimeters. And I don't think, even in hindsight, that this is all related to just his fracture malunion, because that's a lot of shortening, unless he had, an occult physeal injury at the time of accident without a second, radiographic evidence of a physeal injury around the knee, perhaps. But we can talk about it in the discussion. Anyway, so he had a little bit of growth remaining. So I did a pan-GNU left-sided, which is contralateral epiphysiodesis, used implants for the femur and drilling curettage with 2 incisions for the tibia. I didn't epiphysiodese the fibula. He was 12 to 13 years old, 13 years plus. Okay, next one. Okay, so now he is more recently, probably a month or two ago, and I haven't actually treated this child, so it'll be good to get opinions. He's got a 2.8 centimeter leg length difference, primarily coming from the tibial segment. He's got the lateral translation of the tibia. His mechanical axis on the right side is pretty well lined up. And here he is on the left, standing on a 3 centimeter lift underneath the right foot, and his pelvis is slightly overcorrected. So his discrepancy was about 2.8 centimeters. He's got about 12 degrees of recurvatum. He's got a decreased posterior slope. You can see his PPT is 95 on the right and 81 on the left. And on a standing spine x-ray, you could see his left hemipelvis is higher than his right. So he's skeletally mature now. He's probably 14, 15 years old. He's got some low back pain. He doesn't have anterior knee pain, and he sometimes uses a small shoe lift. And the question is, what should we do, if anything? And Maddie, is there a poll question? I think there is. So these are some of the choices. Observe with a shoe lift, do a tibial osteotomy with acute correction at the site of the malunion, do a tibial osteotomy with gradual correction and lengthening using X-fix, do a tibial osteotomy with gradual correction using a lengthening nail, do a proximal tibial osteotomy with gradual correction using X-fix, or just disregard the tibia and lengthen the femur with a lengthening nail. And perhaps number 7 is some other option, which I'm sorry I didn't list. So we can go back to the X-rays, the last picture, just so that we have it and people can answer. And I think we're sort of done with it. And this is to me, it's a great case because it's all over the place. 31% of you said tibial osteotomy with gradual correction using an IM lengthening nail, and that's very interesting. 28% said mid-shaft tibial osteotomy with gradual correction with X-fix. Very few said observe. Well, 13% said observe or do a tibial osteotomy with acute correction. And some said tibial osteotomy with gradual correction. And interestingly, did nobody say, 3% said I am lengthening of the femur, which is interesting. And I can see Sam's here too, probably, because we had a conversation about this last week. And that was sort of my gut initially, to just ignore the tibia. But I'm not going to say anything else. So let's see. Let's open it up. Why do people choose what they chose amongst the panelists? Maybe we'll go through the options. A lot of people said do a tibial shaft osteotomy with a lengthening nail. So perhaps somebody who supported that option can start. What are the challenges and why did you choose that? I mean, we heard there was issues with, possible, poor regenerate, compartment syndrome. It's a pretty distal site for a lengthening nail. But let's hear from the experts. Or I'll pick on someone. Chris or Christof.
I actually didn't choose lengthening nail, and I'll tell you that this is the perfect multi-apical deformity for a hexapod fixator. You've got translation in the coronal plane, you've got apex posterior in the sagittal plane, and you've got an axial deformity of a leg length discrepancy. And so in my hands, I would think fixator would be ideal for this. I didn't choose nail because your last comment is true. I think that the level where you make your osteotomy is going to put you in jeopardy of violating the osteotomy safe zone. So you want to have, in this case, 11 centimeters from the end of your nail before you make your osteotomy. And I can't quite tell from the ruler, but I got a feeling that you're up against that. So those are my thoughts.
Yeah, great. Thank you. Yeah, Christof, go ahead, please.
I'm not sure. Of course, we would need to measure it, but I feel maybe a 215 nail, which is the shortest precise lengthening nail for the tibia, should maybe fit to end before the old fracture. And then you could. It depends a little bit. I don't see the distal tibia so well. If the 8 DTA is acceptable, the LDTA. If the alignment of the tibia in the frontal plane or the distal tibia is acceptable, then I would most likely go for a precise, but a short precise that sort of ends before, because I think the recovatum deformity is nothing that bothers the patient, and you could do a proximal tibial osteotomy. You would need to use some blocking screws to make sure that if you do this high osteotomy, you stay in line with your lengthening, with the axis. But I think that would be my approach, as long as the 215 is the distance you got.
Got it. Okay, thanks. Miguel, you had a hand up, and then Matthew.
Yeah, I think it's a good case for illusory system. I think it's too simple to use a hexapod. I think with a illusory you can solve the whole problem. Doing a proximal osteotomy and the cora is in the middle of the shaft, but you can do another deformity following with the secula of the osteotomies, put the hinges in the place of the cora and do lengthening and correction in the proximal part of the tibia.
Great. Thank you. Matthew, what about you?
I think I agree with that, because I also would do an illusory with the hinges at the cora to correct the deformity. What we see here is a recurvatum, and that can be quite crippling for the child. We don't like recurvatum at all because that becomes difficult. So I would certainly use an illusory external fixator to correct it.
Yeah. Sam?
Yeah, I agree with with the gradual correction. I think you could use an Ilizarov or a hexapod frame. I would go proximal to this deformity just because I think you're going to have better healing. I think these diaphyseal deformities, even in kids, are a lot slower to heal if you go at his current cora in the tibia. I think for folks who are thinking about nailing this, I think you just need to make sure you've got a patent tibia. Otherwise, you're going to be doing a clamshell osteotomy, which is a lot more invasive and problematic for healing. So my vote would be a proximal osteotomy with a hexapod frame correction.
Got it. Mark, you're next, but let me just give you one other reality check here, that I actually talked to this patient about gradual correction with a hexapod, and he and his mom were like, we don't like that monster. We don't want a fixator. So that's not uncommon response, but we could still push it. Okay, Mark, go for it. You could unmute, please.
So, few remarks. First of all, I read the articles that you did on the left side of the distal femur ephysiodesis, I believe temporary. In my hands,
but it was kind of permanent. Yeah. Go ahead.
In my hands, it doesn't work well. I'm not sure that I will get it. The second part, you cannot blame me that I hate external fixation. I'm living with hexapod and illusory and all, but in recent years, if it's any possibility to avoid external fixation, in this case, he has a perfect alignment on the intake, mild recurvatum on the lateral. I would do percutaneous osteotomy, put the nail in the tibia through supramalleolar approach. There is no anterior knee pain after this. And if he has a really more than 2 centimeter lengthening, it's nothing to perform a femoral lengthening through a piriformis or anteretrocanteric, and I will do remaining leg length discrepancy through the femoral lengthening.
Okay, let me just understand your final option. So are you saying you would correct the tibia also and then lengthen the femur if needed?
Just for the leg length discrepancy.
Okay. And I'm sorry, what would you do for the tibia? Just like a one-liner? Would you
percutaneous osteotomy and put the nail to correct the recurvatum of the tibia in the middle of the tibia.
Okay, but not a lengthening nail, just a...
No.
Okay, got it. Okay, all right. Scott, you get the final word.
Yeah, I just wanted to reemphasize what Chris had mentioned. There's multi-apical deformity in the sagittal plane of the tibia. The PPTA looks like it's about 90 degrees when drawing that shaft line down the proximal segment of the tibia, or I should say the mid-segment of a multi-apical deformity. So I agree with the comments that were made about doing external fixator correction above the level of the visible deformity in the proximal metaphysis, because I'm really wondering if the recurvatum in this case seems to be most clinically significant, probably both from the PPTA as well as that midshaft osteotomy, and correcting something in between there and just making a compromise between those two. I don't think it needs two levels of osteotomy, but in that metaphyseal osteotomy, the perfect way to correct it with the external fixator. And I think if the patients don't want an external fixator, they need to have more explanation of how much the benefits of doing that versus the complexities of and risks of other treatments.
Okay, let's just pretend like we're having this conversation, and they've read about an magnetic femoral lengthening nail, and they're like, why not just equalize my leg length? My mechanical axis is good. What's the downside with a 2.5 centimeter knee height asymmetry if your mechanical axis is straight?
Can we ask you, how much do you think his recurvatum bothers him? I mean, clinically speaking.
He has no anterior knee pin. He plays, American football a lot, and he's athletic, but he sees a chiropractor because of back pain.
So maybe we don't need to correct the deformity at all. It's just a lengthening issue. Clinically speaking, it's purely a lengthening issue.
Yep. Yeah. So go ahead, Christof.
But if we agree on that we don't have to correct the deformity, then why don't use a proximal tibial nail, lengthening nail, that is short enough to end above the old fracture? Because the femur on the right side is already longer than on the left due to the epiphyseal usage. So it's not that we start off with a same length femur. So we will make the now already longer femur, even longer.
Yeah.
Nope. Yeah, I totally agree. It's great to correct deformities where they are and not bother other bones to compensate for it. And tibial nail tends to want to make a little bit of procurvatum anyway. And if we get 5 degrees of procurvatum in this case, it might even be a good thing.
Got it. Now, would you intentionally correct the sagittal plane, or would you let the lengthening nail do its thing without a blocking screw, maybe, in the sagittal plane? Scott or
every time I leave out blocking screws, I regret it. But I might put them in a little looser than normal in this case.
Yeah. To me, it's a little tricky because it's sort of, once you've got the nail in, you're sort of done. To me, if feasible, a gradual correction perhaps would be my next choice. But yeah, I think it's a great discussion of how we all sort of, and I think Chris talked about the comfort zone. And I feel we're in comfort zone and panic zone. There's a stretch zone. And I think it's always good to sort of be in the stretch zone and have some friends and mentors around. So, okay. So I think we've caught up in terms of our timing, and we have a 5 to 6 minute break, and then we can reconvene for our third session, which is non-union and bone loss, in about 5 minutes or so. So thank you, everybody. Great session so far.